So thank you so much for joining us, and hopefully we're going to have another interesting ECG today. So for those of you who are on the group and maybe had a look at the ECG, I hope you had a chance to just look through it. After the last two, let's say, difficult ECGs that we had, the one for today is relatively easy. The main point of it is not trying to how can I put it, make a definitive diagnosis, but understanding differentials and how to stack those differentials and then how to move forward from there. And hopefully we'll learn a little bit today. Okay. Now, as usual, if you guys have any questions at any time, please feel free. Just stop, put something up on the chat, just put your hand up, whatever it may be, and then we will go through the ECG. So here you have 21-year-old female patient with chest pain. All right. So there's a few things that need to start going through your mind. Now, chest pain, of course, should elicit an ECG in any case, no matter who your patient is, whatever their age is, even in a young person, even in a child. Chest pain, you should just do an ECG as a routine investigation. It doesn't mean necessarily that you are going to find a cardiac cause, but at least it allows you to exclude a cardiac cause. So remember what I've always said, whenever you are assessing your ECGs, we go through it step by step. So let's go through this one step by step and let's see what we can find. So the first thing that we note is that we've got an axis where we look at lead 1 and lead AVF, and it doesn't matter what system you use, whether it's the thumb method, the quadrant method, whatever you prefer to use, it's no problem. But in this case, we can see both leads 1 and lead AVF are both positive. So this would imply to us that it is a normal electrical axis, which is a good start, but doesn't mean it's going to that everything is okay. It just means electricity is moving in the way that it should. That's about it. So let's look at our rhythm strip next. So for our rhythm strip, the first thing that we look at is our P waves. All right. So our P waves do seem a little bit shallow, but they're not necessarily abnormal. They're within normal. So and they do change a little bit, but generally they're within the normal range. Then we look at our PR interval, which is 1, 2, 3.5. And remember, between 2 to 4 small blocks is regarded as normal. So we've got a normal PR interval. Our QRS complexes are narrow. So that's a good sign. That means the ventricles are responding to the atrial input, and they are contracting based on the atrium. And QRS is following every P. In other words, the ventricle always contracts after the atrium. So that's a good sign for us as well. And as we can see just from that, they're relatively regular. Remember, absolutely regular is not really common. You tend to get sinus arrhythmia and things like that. So it may be just off a little bit, but generally you can see those groups of PQRS are actually quite regular. So this is what we would call a sinus rhythm. Okay. Now, the next thing we're just going to look at is the rate. So well, on the new ECGs, it just gives you the rate, but we'll just work it out here. 1, 2, 3. So just less than 100, maybe about 95, 96 beats per minute. So it's tending towards a tachycardia. So we have a patient with a sinus tachycardia. Okay. So I hope everybody's following so far and you understand how we got up to that point. Now, what we're going to do is that we're going to look at each zone of the heart. So let's look at lead 2, 3, and AVF. So these are our inferior leads. So they're looking at the heart from the inferior point of view. So what we notice in leads 2, not so much in lead 3, but maybe to a small extent, and lead AVF is that we've got this slight ST elevations. Okay. So let's start thinking about differentials. We have a patient, 21 years old, so he's very young, all right? Now, remember, being young doesn't exclude infarction, right? I'm just drawing our stick figure, my brilliant drawing, just because just, think now where we should go from here, all right? So let's just put our heart in there, anatomically correct drawing there, and let's just put all our leads in. So let's just put leads 3, lead AVF, and lead 2. All right. And then from here, we've got lead 1 going out there, lead AVL on that side, and we've got lead AVR on this side, all right? And then just around the heart, we've got leads. Let's put it in another color here. So let's make it a nice pink. So we've got V1, V2, V3, V4, V5, and V6, all right? So just a basic understanding. So what we're looking at is if we have a ST elevations in leads 2, 3, and AVF, how do we say that this is a myocardial infarct? And the one thing that we've discussed over the last few weeks is that generally, in order for us to say that we have a myocardial infarct, we should have reciprocal changes on the opposite side of the heart. So in other words, if the inferior zone is seeing ST elevations, we should be seeing ST depressions on the opposite side. All right. So let's have a look as we're going through and see what do we find. So the first two leads we can look at is our other two limb leads, leads 1 and AVL. So leads 1 and AVL are generally considered as reciprocal to leads 2, 3, and AVF. But what you notice in this case is that we've got an ST elevation as well, although not as pronounced in AVL, but you can definitely see it in lead 1. So does this exclude infarct? No, not really, but it's a bit troublesome now. What's going on? Why does this patient not have reciprocal changes? Okay, if we look at AVR, we can actually see, sorry, what looks like maybe a slight ST depression over there. It's possible, but we also notice this very pronounced PR. If you look at this PR, it looks a bit elevated actually compared to the rest. So this could be a reciprocal change. It's possible, but it should be showing in a few more leads than what we're seeing it at the moment. All right. Let me just get the pointer out there. Sorry about that. Okay. So far what we've seen is that we may have a possible inferior, maybe even a lateral infarct. We need to see something that tells us, okay, this is a possibility. Is this an infarction? So we go to leads V1 and V2. These are our chest leads now that are looking at the septum. And what we notice in lead V2 is that we've got a bit of an ST elevation over there, not really in V1. If we come to leads V3 and V4, which are our anterior leads, we also notice that we've got slight ST elevations as well. So we're seeing ST elevations that are quite widespread. And when we come to leads V5 and V6, which are also considered lateral leads, with 1 and AVR being your high lateral leads, we also see ST elevations on V5 and V6. So what we've got now is we've got this huge amount of ST elevations in a 21-year-old patient. Any ideas on what could be going on or what the possibility may be? It's okay if you don't. I'm just saying, if anybody wants to venture a guess, because now you're sitting with this patient, she's obviously in a lot of discomfort, she's not feeling well, and you have picked up ST elevations without reciprocal changes. So there's a few possibilities when you see this pattern, all right? So the first one is that, yes, this may be a massive infarction. It may be an infarction that's spread throughout the heart, that's involving every single zone, and is showing up on this as or is showing up on the ECG. So that's definitely one possibility. Another possibility that we have to consider, something that does give this pattern, is a ventricular aneurysm. Now, ventricular aneurysm is exactly what it sounds like. You get an aneurysmic wall of a ventricle, but this normally has a history of previous infarcts or previous trauma or previous damage, and I doubt a 21-year-old would just present like that. Then you have things like benign early repolarization, which is a condition that is benign, and in some people they do repolarize or go into their repolarization cycle, their contraction cycle, a bit earlier. So in other words, their baseline electrical activity at that point is a little bit higher. And the one of the others that you get is pericarditis. Okay, so what we're going to do is that we're going to have a look at the differentials, and then we're going to come back here and try and think of what could be the most likely culprit in this case. All right. So let's have a look now. So we've got this 21-year-old. We've maybe done a chest X-ray. We've seen it's clear, or patient is complaining of pain. We've done the ECG. We see this. We send off our enzymes. We suspect that she may have a myocardial infarct. But what if it's not a myocardial infarct? What else could it be? All right. So this is a differential diagnosis for myocardial infarction in patients less than 25 years. So there's quite a few here. All right. But these are the things that you need to think of when you are going through patients such as this. So coronary artery anomalies such as cardiac bridging and things like that, that's a possibility. Hypercoagulable states can definitely lead to that. Patients with Kawasaki's and Takayasu's, which are autoimmune diseases, these can also affect. Substance abuse can definitely cause symptoms similar to an infarct. Myocarditis also, which we've seen a rise of recently. Hypertrophy cardiomyopathy, a bit more common in the young men and very common in steroid users as well. Trauma, aortic dissection, and connective tissue disorders, coronary artery dissection. Now, this is in patients where your enzymes come back as elevated, all right? But in this patient here, there's one particular thing that makes me think that it's not a myocardial infarct, okay? And this is something that you need to remember whenever you are looking at these, because all of these other diagnoses that are here, while they do occur, are not actually that common. And generally, you will get a history that comes along with it. This is more suggestive of a pericarditis. And the reason for that is actually this little PR elevation here in lead AVR. And this is very commonly seen in pericarditis. And pericarditis also gives us these widespread ST elevations as well. Now, does this mean that this ECG is diagnostic of pericarditis? No. You would still have to rule out an infarct. You would still have to rule out a hypercoagulable state. You would still have to rule out other forms of inflammation and other forms of infection. But considering that when you're working in any sort of emergency department, you kind of look for the most common things, so the most common things occur more commonly, and then you go down the list to see what's going on beyond that, right? So let's say this patient does go to you send the patient for labs. You find your CRP is increased, your ESR is increased, your enzymes come back relatively normal, maybe your white cell count is increased, you would start thinking, okay, this could be a pericarditis. And should that come back negative, then of course you would move away from pericarditis as a possible diagnosis. Now, the reason why I wanted to discuss this ECG is because I've seen a lot of our younger doctors and even a lot of the general practitioners in town who I deal with, they tend to struggle with these when they do find them, because it is worrying when you see a whole lot of ST elevations. Am I missing an infarct? And especially in a young patient, am I missing an infarct in a young patient? So the safest thing to do is treat the patient as though they may have an infarct, but in the meantime, check for pericarditis. And the easiest way to check for pericarditis is actually to get your patient to lean forward and lean backwards. And generally, when they lean forward, you'll actually find that their pain is relieved. And when they lean backwards, their pain is actually aggravated. But we'll go through that in a little while. And I just wanted to get to the answer on this because, okay, listen, I was lucky. I get to see the answers before, so that's why I could say it with an acute pericarditis. So I am cheating. But just to make every it's not because I'm extremely clever, it's just that that's the only way to put the presentation together. So the first thing that they talk about is an ectopic atrial rhythm. Now, I don't want you to stress about that too much, but basically what it means is that even though the overall conduction train is starting in the atrium, is not actually starting in the sinoatrial node. It's starting from somewhere else, but that's not important at your level. What's important is to know that it was a sinus rhythm. The rate was a bit high, and if you would call that a sinus tachycardia, nobody would argue with you because you missed an inverted P wave in lead 3, which is here. All right. So this is why they're calling it an ectopic atrial rhythm. And in any case, that is something more for the cardiologists and electrophysiologists to worry about later on. It's not something we worry about. Okay. So what we saw was diffuse ST segment elevation. And the causes of diffuse ST segment elevation include large acute MI, as we had mentioned, acute pericarditis, benign early repolarization, coronary vasospasm, which I missed, and left ventricular hypertrophy, which we didn't see in this patient. Okay, so there's very subtle PR segment depression in a few of the leads, which may also suggest acute pericarditis, and the PR segment elevation is present in lead AVR and is the most suggestive of pericarditis amongst the various entities in the differential diagnosis. So as I said, so if you look at leads 2, V4 and V6, it's a difficult thing to make out, but yes, there is a bit of PR segment depression, but it's very easy to see here in lead AVR. Now, will that happen in every case of pericarditis? No. It does happen very commonly in bacterial pericarditis, but in viral pericarditis, constrictive pericarditis, and autoimmune pericarditis, it doesn't necessarily happen. So the most common form of pericarditis that we see is bacterial, and of course, mycobacterial TB. And those tend to cause those PR segment depression. So again, most commonly you would see those, but if you don't see them, it doesn't mean that they, it's definitely not an acute pericarditis if you don't see that PR segment depression. And of course, in this case, you have to take the patient's age into account as well. All right. So okay, now this is going to look like a lot of reading. So if you want to, you can always take a screenshot of this. I don't mind, but I'm going to show you what all of these ECG findings are on the next page, on the next slide, and a little bit easier as well. So this is just to point out that pericarditis has 4 stages, all right? So the first stage is the acute phase. So that's when the patient is having the acute inflammation. They are, oops, sorry, I already skipped forward to it. And where you see a lot of these ST segment elevations, all right? So the one thing that you'll notice is that they talk about this concave upward facing ST segment elevation. I want to just go back and see if we could see that here. And what you'll notice is that it is there, but to a very slight extent. Now, they used to call this a saddle deformity, but I must be honest, it's a very hard thing to pick up in the acute setting. It's one of those things that when you look back and you've already got a diagnosis based on your bloods and clinical examination, that you would probably say, oh, okay, this does look like it. But I haven't seen many patients where it's very, very apparent right from the beginning. Okay, PR segment depression, reciprocal ST depression in AVR or V1 is also a possibility. Then you go to the subacute phase as the patient is starting to recover, the chronic phase as the patient now is coming out of that acute inflammation, and of course the recovery phase. So most of us will see the patient in the acute phase, and then the subacute, chronic, and recovery phases are normally seen in medical wards thereafter. Okay, so the reason why you have all of these phases happening is that you have this inflammation taking place in the pericardium, and what it's doing is that it's actually affecting the epicardium, and it's also affecting the atrial myocardium. That's the basics of why you get this PR segment depression and why you get the ST elevation. And as the inflammation decreases and changes, and as the myocardium and epicardium start to recover, then you see all of these things. So the easiest way that I would try to remember it, okay, to remember all of the stages. Stage 1 often looks like a massive MI, just like what we saw. Widespread ST elevations all over the place. It looks like a massive MI. And when you see that, it's very easy to ask your patient to lean forward and lean backwards and note the change in pain. And when there is that change in pain, it lets you know that this could well be an acute pericarditis, all right? So because the left ventricle is more commonly involved, well, when I say more commonly involved, what I mean is it occupies a larger part of the pericardium. as your patient leans backwards, it causes irritation of the pericardium. And when they lean forward, it's more of the right atrium and a bit of the right ventricle that's now pressing against the pericardium. So it tends to just give them a bit of relief. Okay. So like I say, stage 1 looks like a massive MI. Stage 2 also looks like a myocardial infarction, but it doesn't look as bad. All right. So if I was to go back to our patient here, we could actually put this patient in the subacute phase. This patient may have been at home with pain for a day or two, may even have been visiting the local GP, may have been visiting another health practitioner, may have received treatment for chest pain, suspected pneumonia, may have received antibiotics and things like that. And that's why the picture looks as it is. Now, in the answer that's given by people who are much more intelligent than me, they have put it down as acute pericarditis. But looking at this, we could say there is a possibility that it is in the subacute phase. And then when you look at stage 3, like I say, it looks terrible. It looks like you need to call the consultant because the patient is going to die because these T waves start to invert so dramatically. Okay, but your patient is not dying. Your patient is just recovering. And it's actually that epicardium that's actually recovering. So that epicardium, as it starts to recover, starts giving you these T-wave inversions. And then stage 4, like I say, it looks like we were worried for nothing because the patient is now in the recovery phase. Okay, so these are the 4 stages of of pericarditis. So the one that's most commonly seen in the emergency department is stage 1. For those of you who move on to do medicine, internal medicine or cardiology, you likely see stage 2 and 3. And please remember stage 3 because I have seen people, suddenly start to panic when they see this, thinking that something is going wrong. But it's just purely, a recovery of the epicardium that causes that. So I hope that makes sense to everybody. Okay, so what do we find in pericarditis? It's quite easy. It has a sharp pleuritic pain, worse on inspiration or lying flat. So that's unfortunately the one thing that our esteemed authors of that ECG book that I've been using don't give us. They don't give us full histories and full physical examinations. But you can see the difference between a myocardial infarct and the pain of a pericarditis. Your acute infarcts tend to be more of a pressure pushing type of pain that's not aggravated or relieved by inspiration or expiration, and it doesn't improve by bending forward or lying backwards. So it's improved by sitting up or leaning forward, like I say, because that takes the pressure of the left ventricle putting its weight onto that pericardium. It just takes it away. You do get pericardial friction. Sorry, I'm not sure if somebody has a question. It's just feedback from the mic. They might have just been feedback from the mic, no problem. Okay, but if you have any questions, please feel free to stop. So pericardial friction rubs, best heard with the diaphragm at the lower sternal border, often described as scratching or grating sound. I've been a doctor now for 23 years. I've never heard it. People talk about it. I've heard recordings of it, but I personally have never heard it. If you do hear it, great for you. I've never heard it, so it's one of those things that if you hear it, great. If you don't base your diagnosis based on that. Patient will have a bit of dyspnea, shortness of breath, often relieved by sitting up, and fever. They may have a low-grade fever. And in our patients who are often prone to getting TB pericarditis, they're also prone to getting TB pericardial effusions. And so your patient may also present with signs of acute cardiac tamponade, which doesn't necessarily occur in the other types of pericarditis. But that's a separate situation completely. Okay, so what are your investigations? Your ECG, echo, if you have the ability to do it or you have access to it. Your chest X-ray is typically normal unless there's a large effusion, which, like I say, more commonly would occur with the TB. Your blood test, as I said, you would have an elevated inflammatory markers and infective markers, ESR, CRP. If you have the option of procalcitonin, also a good test to do. Your troponins may be slightly elevated if there's myocarditis, but not necessarily. You can also do viral serology, autoimmune markers, renal functions, thyroid function, if you suspect that there may be something at play over there, especially if you suspect autoimmune disease. In a patient of that age, it's always possible. So this is how we get to these findings. Now, how do you manage it? Basically, you monitor for signs of tamponade, which is luckily not that common, but it can happen. Intravenous fluids if the patient is hypotensive. But the most important thing is the medical management. So we tend to give them NSAIDs. Colchicine can be used, but in very low amounts in the emergency department. Steroids also can be used, but it's not as effective. It's more effective if you have an autoimmune cause. Antibiotics, if bacterial pericarditis is suspected. And for most patients, until you can prove otherwise, there's no harm in giving a stat dose of antibiotics, stat dose of NSAIDs. There's no real place for opiates in pericarditis unless the pain is becoming unbearable, in which case the patient may respond to some opiates purely for the analgesic part of it. Pericardiocentesis, I would advise that be done by a senior under ultrasound guidance, but only if there's tamponade. When do you admit the patient? I would say we always admit the patient based on what the physicians tell us. But in other words, it's not a patient that you should send home. Sorry about that. So I wouldn't send any of these patients home until they've been seen by a physician or a cardiologist, So if you're working in any hospital, they'll have their own admission protocols. Okay. So that's the end of the presentation. It's just a little joke to finish off. I'm not sure if you guys have any questions or anything that you would like to ask. Like I said, there was a lot of theory in today's because whereas I have discussed pericarditis with you guys, I think on 2 occasions prior to this or in previous sessions, I think last year and the year before, I hadn't concentrated as much on the particular stages of it, as well as the just going through what we need to do as far as this condition is concerned. So I hope you guys enjoyed it. If there are any questions, I'll give you a minute now. And if there aren't any questions, that's no problem. You're more than welcome to message me on the chat should you come up with a question later on WhatsApp or Telegram, or even on the YouTube channel directly in the comments. More than welcome to ask questions if you need to. But I hope this gave you just a basic understanding of how you'd approach a young patient with a severe chest pain and with what looks like a possible myocardial infarction, could well be pericarditis as well. This doesn't exclude myocardial infarction. A myocardial infarction is very possible in young patients. We don't say that they don't get it. It's just that it's less likely, and it normally requires, for example, hyperlipidemias, hypercoagulable states. There's things called channelopathies as well, which are also inherent. There's a lot of autoimmune diseases that can also lead to early myocardial infarct. So it doesn't mean that myocardial infarct is negated by the patient's age. It's just less likely than in an older patient. Or in other words, if you had 100 young people with chest pain, you'd have a much smaller cohort who'd actually be suffering from an infarction. That's basically what it means. But if you guys are okay, if you guys are happy, and if there's no questions, then I just want to thank all of you for taking your time and joining me for the session today. Hopefully on Wednesday we'll have another session. I'll just go through all the presentation and see what we haven't covered, and hopefully we can cover something else. Maybe another blood gas, or maybe a procedure that's common in the emergency department. But until then, I hope all of you guys have a great night, and I hope you'll enjoy it as well. Okay. Keep